Brandeis University, and I'd like to welcome you all to this special organized session on value-based performance, learning from international experiences. So this session is being organized by the research center that's joint between Brandeis and Harvard. That's a center about studying how to improve system performance of substance use disorder treatment. So this is the latest version of a center that's been going on for a number of years. And the current iteration, part of what we're doing is looking at ways that providers of substance abuse treatment get paid. And in the course that we were interested, there's not very much pay for performance going on in that sector. What can we learn about the way pay for performance and value-based purchasing have been used in other sectors of healthcare? So that was the impetus for this session. Obviously, most of it will not be about substance abuse treatment, but we'll be at the back taking notes to get a handle on it. The speakers, we have two speakers, both with plenty of experience in this area. The first speaker is going to be Dr. Meredith Rosenthal, who's a professor of health economics and policy at the Harvard Chan School of Public Health. She's also the Associate Dean of Diversity there and an elected board chair of the Massachusetts Health Quality Partners, which is a multi-stakeholder quality improvement organization. So she is involved with practical issues around pay performance here in Boston and Massachusetts. And she's also a member of the National Academy of Medicine. The second speaker is going to be Dr. Anthony Scott, who heads the Health Economics Research Program at the Melbourne Institute of Applied Economic and Social Research at the University of Melbourne. And he jointly coordinates the Health Economics group there at University of Melbourne. And so Dr. Scott is an associate editor of the Journal of Health Economics, and his research interests focus on behavioral physicians, health workforce incentives, and primary care and hospitals. And he runs a nationally representative panel survey of physicians called MABEL, so that may feature in this today as well. And so the format is going to be each of the two speakers will give a presentation surveying this area, and then we'll have both of them up on stage for half an hour or so of question and answer with the audience about the topic. So with that, let me turn it over to the first speaker, Dr. Meredith Rosenthal.
Good morning, everyone. Thanks for spending your Sunday in the Church of Value-Based Purchasing. I was actually going to include religion in the title of my talk, but decided that it might be in poor taste. So let's see if I can find my slides. Up here. This guy. Yep. Complicated. So in typical American fashion, we're here talking about learning from international experience, and I'm going to tell you about the U.S. experience as a potential case study, from which, of course, we'll have to talk a bit about how to generalize lessons. But the U.S., I would say, arguably has some of the longest and most complex history of implementation of value-based purchasing. So I want to start a little bit with my working definition of value-based purchasing. That term, of course, can be used in many different ways. And so I would say that we're largely looking at activities that rely on the collection and measurement of performance data related to quality and cost, and really using those data in ways that make providers accountable for the effective use of resources. And I know I have colleagues here who think a lot about how we define the effective use of resources in terms of incremental cost effectiveness, and I think there's some interesting work in trying to find the intersection between value-based purchasing and how we think about incremental cost effectiveness. We're not really there on the policy side yet, but very broadly we're talking about measuring, reporting, and ultimately paying for effective use of resources, often in the form of separate quality and cost measures. And in particular, pay for performance has been a major focus of the value-based purchasing activities here in the US, but also public reporting of quality and efficiency information, including also patient experience. I'll say a few words about some alternative payment models that I do think fall under the rubric of value-based purchasing, including ACO models, global payment models that include quality measures. There are other alternative payment models like bundle payment that have no quality measures associated with them, which I would not include in the definition of value-based purchasing for today's purposes. And I'm not going to talk about benefit design tools that maybe use similar sets of quality measures, but really are focused on helping patients navigate healthcare value. So very loosely speaking, the economic logic around value-based purchasing is something akin to you get what you pay for, the title of a paper that we published in this area. Although, strictly speaking, of course, health economists don't really believe that you get what you pay for in healthcare. In fact, we assume and have good reason to believe that clinicians and healthcare, mission-oriented healthcare organizations at least, do in fact deliver services and attributes of services that they are not strictly paid for. So we take these providers as being utility maximizing and not just profit maximizing. But we still believe in general that at the margin you get more of what you pay relatively more for, with of course important caveats around the potential for gaming and other activities that may lead providers to respond to financial and other reputational incentives in ways that are not quite what was intended. That general logic has been very compelling in the US context, where we have a very strong market orientation. While economists and health services researchers have spent the last couple of decades publishing opinion pieces and other policy analyses listing in great detail all the challenges with value-based purchasing, and I would say at the top of the list, I would include the challenges associated with our imperfect ability to measure and adjust for patient characteristics and the potential that these programs may lead to selection of healthier patients, patients who are more likely to adhere to care recommendations that will make the quality of care appear to be stronger. Concerns also related to multitasking and our inability to capture all dimensions of care that we really want to reward. That also, concerns have been raised about the adequacy of payment in the case of pay for performance and demand response in the case of public reporting in terms of motivating whether these value-based purchasing programs will actually motivate quality improvement in the way they are intended, and a whole host of measures associated with, a whole host of problems associated with the performance measures themselves, the extent to which they are truly signals of quality versus very noisy approximations. Despite these well-understood challenges, of course, we've had quite a lot of adoption of value-based purchasing for healthcare providers, hospitals, physicians, and systems of providers. I'll tell you a little bit about what I think we've learned from the US experience over the last 2 decades. So just for those of you who are not as familiar with the US healthcare system, obviously we have a very complicated set of financing and delivery arrangements, and I'm going to focus here on Medicare, which is the largest single payer in the US, while the Medicaid program, at least this week, is bigger in terms of the number of individuals covered. It's not really a single program for all intents and purposes. But Medicare is a federal government program that is financed through payroll taxes, premiums, and general revenues. And the vast majority of providers participate in the Medicare program, which pays physicians on a fee-for-service basis largely, and for hospitals, diagnosis-related groups, so based on these inpatient episodes, in effect, just for the facility payment piece. Importantly, patients have no restriction on the providers that they can go to, so they can see a physician or use a hospital anywhere in the very broad national Medicare network. That is a very high-level overview of the Medicare program. Medicare itself is actually much more complicated than that. I'm really talking about traditional Medicare here, where value-based purchasing has been experimented with. And so thinking about Medicare's experience with value-based purchasing, really the early focus was on hospitals, and it built on a history of hospital accreditation and quality measurement that goes back to the 1950s, in fact, when data were begun to be collected on a voluntary basis, and the government began to get involved in the 1990s with the Oryx initiative, and we're really just talking about getting hospital leaders and clinicians and government officials together to decide on what quality was, how we could measure it, and ultimately coming together to form the Hospital Quality Alliance almost 2 decades ago in order to, it's moving on its own. Hopefully that won't continue. To begin to get some consensus on how to measure and report quality. And so starting in 2002, hospitals were asked to report to Medicare a set of quality measures for a number of key conditions that affected the Medicare population. And I show you here a slide looking at heart failure. And I should also note that these hospital quality slides were generously donated by my colleague Karen Joint, who is now in St. Louis, and has really done some of the leading work on hospital value-based purchasing in the US. And so this slide is from a paper by Scott Williams and colleagues from 2005, looking at the early experience with just collecting and feeding back information to hospitals. You might think of this as the softest version of value-based purchasing, no public reporting, no payment associated with this, really just measurement and sharing of results at a high level. And you can see for heart failure, we have 4 measures here, including some that relate to documentation of processes like giving discharge instructions for patients with heart failure, smoking cessation counseling, as well as some clinical measures, ACE inhibitor use for left ventricular systolic dysfunction, assessment of LV function as well. If you look at the whole set of 16 measures for which the Hospital Quality Alliance originally recommended data collection, most of them actually look more like the smoking cessation and discharge instructions, where you see this gradual improvement over time. A couple of the measures seem to barely move, like the 2 at the top, but overall, the article concludes that there's been some improvement during the time of this measurement and feedback. You'll note, of course, here that we don't really have a pre-intervention period, and we don't have any kind of control group. So we're just really looking at trends in measured performance early on in Medicare, and it seems across the board that we see some improvements over time. Whether or not those can be causally associated with the policy is a little bit unclear. So as momentum built a certain amount of facility with data collection, comfort with the measures was built up, public reporting began to be introduced in the Medicare program, and the Hospital Compare program was created out of this, this baseline. And so I'm just trying to give you the impression that in terms of the hospital value-based purchasing in the US, we have really a 20-year buildup of agreeing on a set of measures, beginning to collect the data privately. Then we move towards Hospital Compare, which is a publicly reported system. There's a consortium of both policymakers, hospital folks, other physician organizations, the AAMC, and we have this very substantial effort that requires hospitals to self-report data, essentially from charts, using chart review that can be audited, but these data are basically manually collected and submitted on a quarterly basis to the government, to the Center for Medicare and Medicaid Services. And of course, earlier on, there had been some experience in the US with public reporting of quality information for cardiac surgery. So this is not the first time that we've had publicly reported quality data, but by far the broadest, most comprehensive effort was Hospital Compare. And so one thing that you see in the Hospital Compare data to begin with, now, first of all, this is a snapshot in Boston for some of our major teaching hospitals, Brigham and Women's, Beth Israel, Boston Medical Center. These data go back to 2005. And you can see for some measures, this one is heart attack patients given aspirin at discharge at baseline. Many hospitals are reporting in at about 100%. So this is another theme that you might have seen in looking at value-based purchasing programs elsewhere, is that, of course, as we think about selecting these measures, there's both a scientific process and a political process to measure selection. And so if the data generally are clustered up around 100%, it's not entirely clear how useful public reporting is. Although other colleagues have shown that then when you stop reporting measures that are performing at these very high levels, that sometimes performance in fact drops. So one thing to note about Hospital Compare is that some measures started out very low. Some of the heart failure measures, for example, relatively lower. Some measures start out already very close to 100%. So there's quite a large variation in the potential upside for public reporting to either lead patients to choose better hospitals. How would you decide which hospital to go to based on these measures, or to motivate hospitals by virtue of simply reputational incentives to improve their quality? There's really obviously not much upside here. So researchers subsequently went on to look at the effect of public reporting on performance. And again, in the case of public reporting, because we had this existing initiative to collect and privately share with hospitals data on their own performance compared to others, we do have some pre-intervention data. We do not have really comparison data, although there are critical access hospitals in the US that are not subject to these value-based purchasing programs, and they're frequently used as a control group. They're quite different from the other acute care hospitals that are being profiled. So if we look at the heart failure scores for quality under Hospital Compare in the pre-period 2003, you can see that for heart failure, we do have a distribution of performance. With, of course, a significant percentage of the density lying towards 100%, but not all in that last column. And then by 2008, which is 3 years into public reporting, we can see that the distribution, in fact, does shift pretty substantially, with fewer and fewer hospitals at these very low ranges and more hospitals in that top category. And these are indices across the measures for heart failure. And similarly for pneumonia, you can see the distribution before public reporting. The distribution after public reporting very substantially has shifted hospitals to this upper category. And so again, with a somewhat better research design than the earlier data, but with no real comparison group here, researchers have concluded that public reporting has improved performance, at least on these measures themselves. Whether overall we've improved heart failure, whether we've improved outcomes, and what other consequences are for patient health overall, I think is a little bit less clear, but some evidence that hospitals are working to improve that measured performance. There has been some research looking at changes in mortality over the same period for the same subsets of patients with heart failure, with pneumonia, with no evidence of improvements in mortality. Of course, one could argue that some of these process measures really shouldn't lead to the kinds of short-term improvements in mortality that people were looking at. Nonetheless, there's no strong evidence of improvement in outcomes. There's a much larger literature on public reporting in healthcare in the US, and overall, that literature has been somewhat negative in terms of both consumer response and overall quality improvement. And as these public reporting programs were unfolding, policymakers had really already moved on to the conclusion that in order for value-based purchasing to be effective, there would need to be money associated with it. Surveys of hospital executives concluded similarly that while public reporting may be initially motivating, if there was no additional funding for quality improvements, there would be no way for hospitals to justify longer-term investments that might improve quality in these areas. Roughly 15 years ago, the federal government began planning for a pilot study of pay-for-performance in the hospital context. And so this was a voluntary pilot of self-selected hospitals from the Premier organization, which is essentially a group purchasing and quality improvement entity that includes many academic hospitals in the US, many very sophisticated hospitals that were more likely to have electronic health records and relatively well-developed quality improvement programs. And they selected a set of measures that were tied also to that same Hospital Quality Alliance set of measures. So again, these measures have been around for a while, and they have the advantage that they're hard to argue against, and hospitals as well as payers have agreed that they're likely to matter. We might think at this point, now that these measures have gotten much greatly improved from public reporting, that there might not be a lot of benefit left in focusing on these same measures, but they're very acceptable. And they also included risk-adjusted mortality as part of this pay-for-performance pilot for heart attack, AMI, and coronary artery bypass graft surgery. So two hospital episodes that have relatively high rates of mortality. Mortality rates for these other conditions, pneumonia, heart failure, and hip and knee replacement, are simply too low to really measure any kind of reliable difference. And so the rules in this first Medicare pilot were essentially based around a tournament. So in the top 2 deciles of performance, hospitals could earn either 2% for the top decile or 1% bonus relative to their total Medicare payments in those DRGs. In the bottom 2 deciles, a penalty was possible, and there were some additional rewards for very substantial improvements. The penalties essentially related to only hospitals who, over the period of the pilot, were unable to improve care sufficiently to move out of the original setting of the bottom decile. So those were not tournament-style penalties. These designs have the advantage of simplicity. Many executives that we talked to at the time sort of felt that this idea of grading basically based on the distribution of performance made sense, that rewarding the top groups of hospitals was a simple and appealing approach. There are some advantages and disadvantages of using those kinds of relative performance scales, and we can talk a little bit more about whether the evidence gathered from this experiment tells us anything about the relative advantage of that approach. So these data come from Peter Lindenauer's paper evaluating the Premier demonstration. Without a p-value, you can squint and decide for yourself whether you see substantial improvements in the pay-for-performance group compared to other hospitals who are subject to the same public reporting. So public reporting is ongoing for all hospitals during this time period, so it's the incremental effect of the pay-for-performance pilot. And Lindenauer concludes that there were a couple of measures on which the pay-for-performance hospitals improve by more than the comparison group, but many measures did not improve. Over the longer period, Werner et al. And others have shown that essentially any gains in pay for performance from these incentives diminished and disappeared by about 2008. And so, to the extent that improvements in these particular measures save lives, those are still real lives saved early on in the period. But given the administrative costs of undertaking a program of this complexity, one does have to ask, what is the cost effectiveness of pay for performance here, given that we're talking about 1 to 2 percentage point improvements and a couple of measures that ultimately attenuate. So other researchers, Ashish Shah and colleagues, have looked at these data also and asked, again, do we see outcome improvements? Do we really see patients living longer as a result of pay for performance? Some of these process measures, like documentation of discharge instructions for heart failure, while one can argue that they are necessary, they're clearly not sufficient for a health gain. So if we look at the two trend lines in terms of mortality for the premier hospitals versus the comparison hospitals, again, you could ask for a p-value, or you could trust your eyes. They do have a p-value. So this is sort of the testing ground for value-based purchasing in the U.S., and the Affordable Care Act then became the vehicle for expanding value-based purchasing much more comprehensively. Again, hospital public reporting is an ongoing undertaking now with increasing numbers of measures, and that continues. In the Affordable Care Act really accelerated the adoption of pay for performance, both for hospitals and for physicians. So the hospital value-based purchasing program, just to really confuse you, they have a program called value-based purchasing, which I don't think includes everything that is value-based purchasing, but that's the key, really sort of the rollout of the results of the Premier demonstration, you might think, given that Premier was intended to be a pilot, as well as a physician value-based purchasing program that is just now being implemented, and I'll tell you a little bit about that as well as a number of other payment reforms, I think most notably accountable care organizations, a concept of a delivery system model with a payment system attached to it that uses capitation, and in this case, there's a pilot that uses capitation in terms of prospective payment. The mainstream version of accountable care organizations uses a shared savings arrangement, so a soft capitation over a narrow range, as well as a number of other payment models. And so a takeaway from some of this is that there are a lot of different payment reforms happening. This is only in traditional Medicare. Forget about what's going on with other payers, including other parts of Medicare. So a lot of these different payment reforms going on at once. Many of them are voluntary. Hospital value-based purchasing is not voluntary, but accountable care organization, bundle payment, these are voluntary. So the complexity of trying to study the effects of value-based purchasing in this context is an extremely important challenge. And so the hospital value-based purchasing program is fully implemented now and includes measures related to the cost of care, to outcomes, to patient experience, as well as process measures of quality. So a very wide range of measures. It's two-sided. There's a bonus and a penalty. It's designed very differently than the Premier demonstration. It includes a point system, both for overall level of attainment, but also for improvement relative to baseline. The improvement score is a failure rate reduction. Again, the high-level headline here is these are very complex programs, and for a hospital to figure out how to allocate their effort in order to maximize sort of their well-being under these programs is a very complex undertaking. And in addition to this value-based purchasing program, Medicare introduced the Hospital Readmission Reduction Program and the Hospital Acquired Condition Reduction Program, both of which are penalties that are relatively simple, but are designed in ways that most health economists and health services researchers would say on the face of them are very suboptimal. They basically penalize the poorest performers, and they include relatively little adjustment for patient factors, most notably for patient social risk factors. Ex ante, most people assumed that hospitals serving poorer populations would be more penalized. Ex post, we observed that they were more likely to be penalized. But they're very simple programs, very easy to understand. So the evidence on these programs you can interpret in many different ways, and there have been many efforts to evaluate them. The hospital value-based purchasing program, overall, there's little evidence. It's relatively early days, I would say, in the implementation, but little evidence that there is improvement related to that program. The readmission reduction program, which we know penalizes hospitals that serve poor patients, does seem to have had greater effects. The evaluations there have taken different approaches, some of which are stronger than others. But across the evaluations, there's some sense that this program has been effective in reducing readmissions, which were already decreasing at the time it was implemented. And the evidence related to the hack penalties is relatively mixed, with some evidence of small improvements in some areas and not in others. And so, I should also note that the Medicare ACOs, which I mostly put in here because I think they have a policy importance. This is, again, an attempt to really delegate the problem of value-based purchasing to a health system, as opposed to having Medicare try to pay individual hospitals and doctors. These programs have shown very mixed results as well. The different models of Medicare ACOs have had different effects. The shared savings program, which has relatively modest incentives, has showed savings only really for early adopters and not so much for the larger set of hospitals that came online after 2011. But ACOs do, I think, represent an important alternative pathway that we might talk about in light of what we know about value-based purchasing. And just a few words about what's coming for physicians, what's currently happening for physicians under Medicare, the merit-based incentive payment system, which was in part launched by the Affordable Care Act and then amended by legislation called MACRA. Includes payment incentives related to quality, some efforts to improve care under clinical practice improvement, and advancing care information is information technology, adoption and demonstration of its use, and then a resource use and efficiency measure. So even for individual physicians, we have this very complicated formula that has different weights for different measures, and also its own scoring system. And just to make it more complicated, the quality measures, one can select from a menu, so every physician practice can pick a different measure from a menu. So what have we learned in the U.S.? I would say we have proven that value-based purchasing can work for some measures for some providers, but the effects have been shown to be quite small, and the long-run effects, I think, are very much in doubt. The biggest impact that we've seen so far has really been for the hospital readmission reduction program, which we think has a terrible design. And others, including Tim Doran, who I think is not here today, and colleagues who wrote this up in the Annual Review of Public Health, trying to make sense of the U.S. experience in value-based purchasing, have concluded that the simpler programs are more likely to be effective, even if they don't really sort of meet our standards for incentive design, that perhaps providers are simply responding to a bright light in a particular space and not really making calculated decisions based on the nuances of the design that those of us who study incentives really tend to obsess about. I confess I'm not entirely sure whether the glass is half empty or half full for value-based purchasing based on the US experience. Wearing my academic economist hat, I would say yesterday we had a really wonderful session in this room. Lots of people from around the globe talking about testing incentives for physicians, and so many interesting behavioral questions. We really haven't even asked any of these questions in the design of our programs. None of the Medicare pilots are multi-arm. They are sort of a single arm. So it's very hard to know what we've really learned from them. So there's much to be learned. I continue to be interested in the work that my colleagues are doing around this, but I do so with a certain sense of guilt. Because I think on the policy side, I don't think that anything that we're interested in as academic health economists is feasible. And so there's this complete disconnect between the interesting incentive questions and the politically feasible alternatives. And I think it's reasonable for someone to say both, well, the data don't tell us much because the studies aren't designed well and the actual incentives aren't designed well. But I think it's also reasonable to say, how many more null studies do you need to suggest that you should look elsewhere for a solution to our healthcare effectiveness and cost problems? So I guess another thing to note is that in the US, as I mentioned before, we keep rolling out these programs and they layer on top of each other in a way that's very complex, both for studying their effects, but also for providers to try to decide how they should respond. The UK has a nice alternative approach, which is they just keep flipping them. And almost surely the full effects of these programs require a certain amount of predictability, a certain amount of simplicity, and that's really not what we're getting from a policy perspective. And I think that value-based purchasing is very often political cover or window dressing for cost control. And that is very much the case in some of the US programs. I'm not necessarily saying that that's a bad thing. But I remain a little conflicted about what to suggest to policymakers in terms of value-based purchasing. Surely we can do better than we have, but it's not entirely clear whether the ways that we can do better are really going to be feasible. So I look forward to the discussion, and Tony is going to really give you the global view on the evidence, and then we'll talk about where to go from here. Thank you.
Okay, well, yes, Meredith said to me before, we should really try and say something positive. And so we both have been thinking along the same kind of lines about what can we do as researchers, as academics who are interested in this to kind of make it happen or put it to bed. What I want to talk about is a recent review that we've done largely, but I'll touch on some similar issues that Meredith has talked about, and certainly Meredith did give us some good context about what these schemes are in the US, how they've evolved, and what their general effects have been. So I just want to talk about, well, very briefly, what is value-based healthcare. Talk about a literature review that we had published last year, and try and think about some positive implications for research and policy. Value-based healthcare, I've used value-based healthcare rather than value-based purchasing, although that's about incentives particularly. A lot of it's about accountability and governments wanting providers to be accountable, and that alone is valuable to governments, even if these schemes don't work. So the fact that they are seen to be measuring outcomes and reporting outcomes is valuable in itself, I think, even if it doesn't work. There's a big emphasis on reducing waste and choosing wisely campaign, and that also throws up a whole new set of measures of low-value care, which we can use and publicly report. I think the key thing for me, which value-based healthcare means, is combining the desire for high-quality care and reduced cost. And it's those two things together, and trying to incentivize those both things is quite important. And I'll talk about that throughout the presentation. Obviously, we don't want to do those. We want to do those. But the ones in between, we're not sure about. Low-value care is there. That's more of a medical definition of value-based care. As economists, we look at cost-effectiveness, and we know that it'll be pretty impossible to try to set priorities according to cost-effectiveness rank lists of different things. But certainly on a broad level, governments do use cost-effectiveness criteria to fund pharmaceuticals, particularly in Australia and other places. And that's a bit of the value-based purchasing that I'm not going to talk about. It's mainly about providers. But certainly we are far away from this, and I'm not sure that we'll get there with that. So the issues about value-based healthcare is really trying to look at low-value care things which aren't effective, but also things which don't cost. Now, this is a framework which has been developed in the US to give us an idea of how to classify these alternative payment models. On the left, we have the basic fee for service, no link to quality and value. Then we have category 2, which kind of links into quality and value a bit, pay for reporting, rewards for performance, or penalties. Category 3 begins to introduce gain sharing or these kind of shared savings models. So we'll begin on top of pay for performance to introduce rewards for saving money as well. And to me, that's the key recent innovation in the US. It's not just pay for performance, which is essentially about quality. It's about rewarding for low cost as well. And there's different models. And it's quite a neat framework, and I'm going to use it in our review to try and classify some of the studies. We need it for various reasons which we know about, so I won't talk very much about that. But we all agree that we need to improve healthcare in an efficient way. In the US, again, as Meredith has said, it's all been happening in terms of these innovations. And statements a couple of years ago, at least from Medicare, just show where they want to be in terms of trying to share. I'm not quite sure how far they've got right now, but certainly to try to link payments and funding models to quality or value is a real big push, and it's not happening in any other country to this extent. So the US is a very important test bed, but it does make the rest of us a bit cautious as well. There are loads of reviews of pay performance. So when we're doing a new one, we think, well, how can we add to these apart from saying, well, it doesn't work again? What we want to do, and this paper was published in Medical Care Research and Review just in December last year, and I'll go through that. But what we really want to do is update the findings in the context of value-based purchasing specifically, and that is specifically about rewarding for quality and cost savings in the same scheme. And that's how we add to at least these other literature reviews that have gone on. So we'll focus on cost and quality as well as pay for performance. Previous studies previous reviews use a narrative synthesis, the synthesized, because the outcomes are very heterogeneous. There's no meta-analysis, so we attempt to conduct a meta-analysis here to try and get some overall view about how whether these schemes work or not. Our search strategy was relatively straightforward. It wasn't as detailed as a Cochrane-style one. We only used a few different search terms, but we did screen the citations of included papers and looked at who cited previous reviews. And so I think I think even though we used limited search terms, we did get quite most of the studies, I hope, are in there. We excluded qualitative other reviews, editorials, opinion pieces. In terms of study design, we excluded before and after and control before and after studies that with no control group and no attempt to adjust for confounders. So those before and after which only compare means, they don't do regression, we kicked those out. We included studies published since 2010 and up until July 2015. This year we're going to update this review, because there has been other studies come out since. We looked at the impact on any type of outcome. We looked at incentives targeted at individual or groups of doctors or hospitals. And the study designs that we did include was before and after studies, control before and after studies that use regression analysis to at least attempt to control for some confounders, observables, and interpreted time series difference in randomized trials. As I said, we wanted to, again, only include those studies which either have a pay performance element or interventions which include pay performance and shared savings or some incentives to reduce cost as well. So there's lots of heterogeneity in outcomes and across these studies, vastly different interventions, vastly different outcomes. So what we did was use vote counting, which is really what we measured from each study was the proportion of positive and statistically significant outcomes per study and per scheme. Okay, so this just gives us an estimate of the probability, essentially, that something will, that the schemes will work. So we're not looking at effect sizes, because again, the outcomes are too heterogeneous. This is the information we got from the studies, and these essentially formed our independent variables, if you like, because you do run a regression. Country of the study, whether the scheme was targeted hospitals or primary care. So, you know, we know that that's important because a lot of the hospital schemes, and particularly the Premier scheme that Meredith was talking about, we know that the money just paid to the hospital and the physicians don't see any of it. That's one reason why they might not be effective. Primary care, the incentives could be more salient and therefore more effective. Whether the scheme included rewards for quality, which is that APM category 2, or for both quality and costs, which is some of the Medicare models that Meredith talked about, and also the alternative quality contract here in Boston. We tried to extract whether payments could be used as physician income, whether there was discretion as to their use, so the organisation could use them for whatever, or whether they could only be used for specific purposes but not physician income. Okay, so again, how salient are these incentives to physicians and providers, and what the rules about how they can use them? Are incentives strong if they can use them as personal income or not? Whether the scheme provided incentives for performance improvement rather than meeting a single threshold, and this is one of the design features that people have talked about a lot. We distinguished those with just a single threshold versus others which had multiple thresholds. So over time, you can move between thresholds, or those which actually rewarded for a percentage increase in performance, which means that those at the bottom of the distribution are incentivized just as well as those at the top. We also looked at the percentage size of the incentive payment relative to total revenue. So does size matter in the study design? So we extracted these data from the studies. We didn't extract these data from any reports or things that went into put the studies together, but I'll talk about that later. So there's an issue about whether we can improve the quality of this data. Because often what's reported in the studies in a small 2,000-word article in the New England Journal of Medicine, we're not picking everything up here. So our dependent variable is a proportion of positive and statistically significant outcomes. The proportion, because it's bounded at 0 and 1, and it has a lot of observations at 0 and 1, we use a fractional logit, implement that using generalized linear model with a logit link function. We have a hierarchical structure. For example, there are several studies of the single schemes. There's been lots of studies of the Premier scheme, lots of studies of the alternative quality contract. There's a correlation of unobservables of studies within schemes. So we cluster observations by scheme, and that's a bit more flexible than using a random effects model. We can't use fixed effects because we want to look at scheme-specific characteristics, and they would be wiped out. So we included 80 papers in the review at the end of it, and as I said, I think there's been a few more studies since then. This is a table of just the characteristics of some of the studies. So I had studies across 10 different countries. The most numerous were from the US, but also in the United Kingdom. So a lot of those were looking at the Quality and Outcomes Framework, but also the Advancing Quality Initiative, which copied the Premier scheme in Northwest England. 80 studies covering 44 different schemes. So again, there was lots of different studies on the same scheme. 55 looked at multi-specialty primary care physicians, and about 25 were focused on hospitals. So that's a general look at the proportion of studies. Overall effects. Well, pretty much, you can toss a coin as to whether these schemes are going to work or not. So out of all those studies and schemes, there was over 1,300 outcome measures measured and looked at in those studies. About just under half of those were positive and statistically significant at the 10% level. By incentive scheme, again, there were quite a range of different outcomes per schemes. There's about 29 different outcomes per scheme which were measured across these studies. And some schemes had over 300 different outcome measures measured, and we include in that any subgroup analysis that the study included as well. But again, overall, the proportion of positive outcomes per scheme was just over half. And each study, rather than scheme, measured on average about 16 different outcomes. But actually, very few of them adjusted for multiple hypothesis testing, which is another methodological issue with some of those studies. So overall, you can pretty much toss a coin. Effects by country. This is just the raw data. So we take those outcomes and just average them by country. And we can see Taiwan is up there as the most effective, at least in terms of the raw data. The US is fourth, but the US at 0.56 is about the same as all other non-US countries. So, the US isn't any better or worse compared to some other countries. And again, so we can see with each of those countries the number of outcomes measured, the number of studies conducted, the number of schemes that were evaluated in each of those countries. So again, the US and the UK certainly dominate those numbers. Okay, here's the regression results. Now, we'll just focus on Model 1, where we had the most dependent variables. There were some missing values. What we see is the first set of variables, the first set of 3 variables are categorical variables about the particular study design. So compared to before and after with some regression, difference in different studies, the proportion of positive and statistically significant outcomes is 24.6% percentage points lower than the average. So clearly, this shows that well-designed studies have a lower probability of being effective. Okay, and when you look at this literature, there's many more different studies than there was 10 years ago. So we didn't look at the quality of studies specifically, so we didn't do a Cochrane-style critique of quality. We just classified these studies into these designs, and you can infer that some studies might be better quality than others. So we don't know whether these different studies were well conducted or not. We didn't look at that. So that's important. Similarly with ITS studies and RCTs, again, a much lower proportion statistically significant outcomes. Studies done in the US, that wasn't significant compared to other countries. Studies done in hospitals, negative coefficient, but again, not significant. Those studies which looked at cost and quality together versus PAFE performance alone, a positive effect, but not significant. So they were 10 percentage points more likely to have a positive effect. And again, those are mainly dominated by the US studies. Those studies which rewarded for improvement rather than a single threshold had lower probability of being effective. So again, that goes against some of our priors about, if we increase the complexity of the scheme, is that better or not? This suggests that some of the simple schemes might have been more effective. And the last two variables are about how providers used incentives. The omitted category is whether they could use it for physician income or not. And again, there's some weak evidence that those where there was a specific use assigned, i.e. you have to use those funds for quality improvement, for example, they had a higher probability of having a positive effect. But again, that's not very strong effect. Now, without some of the missing variables in the second column, we can see that we increased the sample size from 77 to 80 studies, the full 80. But even just adding those 3 studies, there's some largest changes in the marginal effects of these studies, again suggesting that where the results could be sensitive to the sample size. So again, this gives us some evidence that that the strongest elements affecting the probability that these schemes might work. Study design matters, clearly, but some of the design characteristics of the schemes itself don't seem to matter too much overall, in terms of at least what we could measure. So this is just going through some of those, so I've said all that, I think. The one issue with about how the incentives payments were used and by whom, studies simply reported the rules. No study reported what incentives were actually used for. There was no follow-up of that. Money was given to providers. That's all the researchers really looked at. We don't really look at what this money was used for. Did it go into general revenues? Did a hospital have a certain internal financial budgeting model, which meant that those incentives were drilled down to hospital departments or providers themselves? We just don't know anything about that. And that is a key area of future research, I think. So there was, with performance improvement again, I mean, some of these schemes, such as a Premier scheme in the US, actually changed the scheme over time. And so capturing that in our model was a bit tricky, so we need to think about that a bit more in terms of how we look at different incentive designs. Size doesn't matter. Only 22 schemes reported out of 44 of those studies that we saw actually reported what the relative size of the incentive was. This seems a pretty major omission. So there's a lot of things from this about how do you report the characteristics of these schemes in the literature, and really that there isn't a standard, and some schemes don't tell us anything about the size of the incentive. But again, we didn't go back to some of the original government reports or how the incentives were designed, but that information could be there, so we could do better with this. But again, it's pretty flat, really. Why is that? Well, it might be that, the marginality of income to providers is quite small. It might be that, just although we expect size to matter, it simply doesn't. So, we can toss a coin. Few design features of the incentives seem to have a positive impact on effectiveness. So that's contrary to what we think. As economists, we'll all love to look at the design, the detail of the design, and what happens there. But certainly, it's something that is not coming through in this. Better design studies, so the different studies only have around a 30% chance of being effective. Okay, so again, there's some limitations of what we did. Simple vote counting, so a study with a large effect, we counted the same as a study with a small effect. That's an issue, but again, it's very hard to merge these very heterogeneous studies. We've done that, but whether that's appropriate, we welcome some of your comments on that. It was not a full critical review, so as I said, we didn't look at whether the different studies were well conducted, whether they all looked at the parallel trends assumption and other things like that. We use limited search terms, but we believe we've got more studies from our knowledge. Small sample size, we want to obviously improve that and get better data. Issues, lots of heterogeneity, some of which we haven't captured. Some of these schemes evolved over time. How do you capture that in this kind of analysis? Quality evaluations are still variable, and as I said, the quality of reporting in the literature of key design elements is very variable indeed in order to do something like this. What we still don't know. So, is rewarding for quality and reducing costs at the same time through shared savings models, which depend on quality, is that better than pay for performance alone? That's been the major innovation in the US in the last few years, and the jury's still out. Shared savings is something which is as old as GP fund holding in the UK. That was shared savings, but with no quality. But nevertheless, do those models work? What do providers use the money for? We don't know. There's nothing in the literature about that. We need to find that out. Scheme design. Now, we all would love to have the fancy design, which worked in theory, but really, is that something that would be implementable, as Meredith said? Are more complex schemes worse? If you read some of the early incentives literature, some of the papers by Prendergast in 1999, they say, well, if it's too complicated, it's just not going to work, particularly in an area where you've got very complex outcomes. It works in a factory with widgets, but not in healthcare. So, with altruistic providers, you don't need strong incentive schemes already trying to do their best for patients. So where do we draw the line? There are political issues about design, which I think that it's very hard to overcome, and Meredith alluded to this as well. Governments want to spend as little money as possible and get as much behaviour change from providers. Providers don't want to change their behaviour at all and extract as much money from government as possible. And the providers normally win. They're strong negotiators in many countries. And any perfect design that you might design is going to be negotiated away so that it simply doesn't work. So how you get over that, I'm not sure that you can. It needs a brave politician. And as Meredith said, there's also selection of providers and patients in these schemes. Very few of these studies explicitly model selection. So some studies just say, okay, we'll take a medical group over time. We only want to look at medical groups that haven't changed over time. But actually, the effects of these schemes could be due to selection if we actually find any effects. So, should we just kind of call it quits? Or is it still too early to tell? It's clearly some of these schemes do work in certain contexts. And maybe they just work for a short time, but they still have some, one-off effects. It's really about, from government's perspective, how do you enhance accountability? And if that's enough for governments, then maybe some simple scheme, which they really know that's not going to work, but it's out there. They're being seen to look at to try and enhance accountability. Maybe that's enough for that political electoral cycle. Are reputational peer group incentives, public reporting a better intervention? It seems to be that many of these interventions aren't simply about pay for performance or value-based purchasing. There's a whole other set of interventions going on beforehand in terms of data collection, investment in IT and information, public reporting, which happen before the incentives are added on. Should we just stop there? Because reputation incentives are strong. There's lots of evidence out there that if doctors are fed back performance relative to their peers or publicly reported, that providers respond much more to that information than consumers ever do. And I think there is, again, picking up from our session yesterday, there is much more of a role for behavioural economics in really enhancing our understanding of how doctors perceive incentives, whether they perceive changes in funding as losses or gains, in particular in terms of their context. So I think that is still an important area of research. Thank you.
So, can I ask a question?
Sure. Yes.
So what would you tell the government in Australia or in the state where you are? What would you tell them to do? Since it sounds like Australia is not out in front. They have the advantage
been very cautious.
The advantage of lateness. So
the advantage of lateness, they've been quite cautious, but still, I think when they're designing schemes, they don't really think about the design. And one of the things that we wanted to look at in our review but couldn't was just the extent to which, to try and capture the extent to which, how the design came about. But we can't do that from the studies because people just don't report that. They just say, here is the design. But looking back into previous documents would help us to work out, well, actually what, did they use theory? Did they actually think about it? And so that's something which is important. But then again, I think they do tend to think about what's implementable rather than what works. So I think, the caution is warranted. Australia is still doing stuff, but again, they haven't really measured quality as much as the US. There's not many routine measures of quality other than the basic hospital data. So unless you have the quality measures first, it's very hard to do that anyway. So.
If people from the audience have questions, if you could come up to one of the mics, because the session's being streamed, and that way your question can be heard by the online audience and everybody. Thanks.
I'm Donald Shepard from Brandeis. Great session. Question on the literature review for the Australian part. We've been working some on a World Bank project and we'll be presenting results from Zimbabwe. They use another term called results-based financing, and I wasn't sure whether you included that as one of the synonyms in your review. There are about 29 schemes that the World Bank has helped to support, and many other donors have also done those, primarily in low and middle income countries. The Zimbabwe results that we'll present were controlled and were favorable as we presented late tomorrow.
Yeah, I mean, as I say, we try to capture as much as we could up until July 2015. So there's lots of stuff been going on since then as well that we haven't yet included, but we do want to include that. So we did try to identify schemes from low and middle income countries as well, where we could.
Thanks.
Yeah.
And a follow on, if you found a 50-50 chance, it seems like since you used a P of 0.1, that anything above a 10% probability is sort of a 10% success, is really quite favorable. So if you, because you applied a level of statistical significance, not simply whether it was in the favorable or unfavorable direction. So doesn't it mean that on balance these schemes, there is substantial evidence that these schemes are somewhat successful?
Counting stuff, we didn't find any negative effects in the review, so it was all positive, or just null, zero. But I think that there are some issues with vote counting about how you count a positive effect. I think the Cochrane collaboration folk tend to tell you to ignore statistical significance and just count any positive effect. but I think we included statistical significance because I think most of the studies were quite large in number, so sample size issues wasn't a great problem, where it might be in some smaller clinical studies that the Cognitive Collaboration based their rules on. So, but yeah, I think if we didn't use 10%, we'd probably overestimate the effects a little bit. But
Okay. Yeah. Thank you.
I think, it's funny because I was looking at that number too, Tony, and thinking, oh, well, half sounds pretty good. But as you also saw, the studies mostly include multiple measures. Often, some of them have 100 outcomes. And there's no adjustment for multiple outcomes. And so that's the coin flip. so it is, I think it's very hard to decide whether it's half full or half empty.
Okay. Thanks.
Hello, Tamer Abdelgawad from Pfizer. I have a question for each of you. I'll start with the shorter question for Anthony. Could you comment on publication bias? Most of these results are only going to be published if the authors had something usually positive to say. So I wonder, how
I've
much...
published lots of null studies. I know Tony has too.
But you might have the reputation to do that, but I would say a lot of people...
I'm not sure if that's a good thing or not.
Yeah. So I'm just curious.
No,
if you could comment
we
on
didn't
that.
look at that. So we didn't try and find studies which hadn't been published. I think that where they're not. Obviously clinical trials are registered, so you can find them a bit easier. But with these kind of studies, if it doesn't work, it might be a report somewhere, which is harder to find anyway. But yeah, it's an issue that.
Sure. Do you have any sense of how much that would discount your estimates?
No.
Okay. And then a question for Meredith. So if we think about just quality in general, not just specifically value-based pricing and the specific government programs, certainly in the U.S., it seems to me that over the period that you were looking at, the early 2000s through now, the role of the patient and patient choice, I haven't seen examined, and it may be in the literature, I'm not familiar with it. But what I'm thinking about here is that hospitals have marketing budgets. They advertise. If you drive anywhere, you see billboards. I'm sure they have presence on social media. I'm sure there are blogs and forums where people discuss their experiences. If I think about a typical patient choice about which hospital to go to for a procedure that's not urgent, usually you'll ask your friends, you'll ask people, you'll go online and so on. And it seems to me that that could be a huge confounding factor relative to whether the hospital gets a 1% bonus for, meeting a certain target or improving quality versus the quality effects of reputation and patient-driven quality. So I'm just curious what your thoughts on that are.
Yeah, so that sounds like a big topic. I'm not sure if it's confounding. So if you believe that over the same period there's a big increase in consumerism along the lines of the same dimensions of quality, then maybe we would say it's public reporting or value-based purchasing, and in fact it's standard market demand. I think the evidence on consumer decision-making in the U.S. context around the quality of care is that quality that patients perceive is very different from the kinds of quality measures that we're looking here. So I know you're saying, so more generally, there are other forces. Consumerism is a force for quality improvement. Almost surely it's focused on a very different set of measures. So it's a really interesting question, but I think it's quite different, which raises the question, if consumers don't think beta blockers after a heart attack and all the complication measures that we put out there are important enough to act on them, are we necessarily improving healthcare in ways that make economic sense? It's a good question. I'm not sure. Yeah.
Thank you.
So how many people in the audience think the glass is half full? And less than half.
50-50 is wrong.
Yes. Yeah.
Hi, my name is Alex Gertner. I'm a medical student at the University of North Carolina, Chapel Hill. So my question is, it may be a little bit outside the field of economics, but are you aware of studies or programs that actually had providers participate in the design of the schemes, or have looked at whether providers are aware or approve of the schemes?
I mean, I know that in Australia, if providers aren't involved in the schemes, they'll be held to pay, right? So, you know, it's politically advantageous to involve providers, at least at a government level. There will be panels of providers and doctors and physicians, hospitals who are involved in how these schemes are designed. So I'm not, you know, a scheme designed without providers at all would be quite rare, I would guess, and it would take a strong government or a very weak medical profession for that to happen.
I think that there's probably a difference between the professional organizations and the rank and file physicians who may be very unaware of what goes into a scheme or how to interpret it. So there have been some, you know, when pay for performance really took off here about 15 years ago, there were some physician surveys in terms of their understanding of the schemes and their belief in how they should be designed. You know, physicians, obviously, they're very concerned about fairness issues in the measurement and the attribution of performance to a particular physician. So those concerns are there. But I do think that, you know, particularly the government schemes, they tend to be very much driven by the professional associations. That's certainly true in the case of Medicare. And that, you know, that's the physician pay for performance scheme that was implemented under MACRA it's a compromise, it's a negotiation in effect between Congress and the professional organizations in order to overcome challenges in the way Medicare cost control policy was working. So yeah, so it's a good question, but they are very much a product of this either governmental negotiation or a market-based negotiation in the case of private insurance plans, who obviously have to be concerned that if they implement a scheme that the physicians don't like, they will leave their network.
Thank you. A related question I have from being involved in hospital quality improvement is that I know sometimes, you know, it's the prostate cancer screenings that need a little help coming up. Sometimes it's the breast cancer screenings. So are there approaches to this that have tried to incorporate a dynamic element that's a bit more responsive to what the problem might be in a particular place at a particular time?
I think the dynamic elements of these schemes are, again, haven't really been thought about. I think, you know, some of these schemes have changed over time in response to, you know, certain indicators topping out or whatever, and particularly the Quality and Outcomes Framework in the UK, they removed indicators, included new ones. So that is an ongoing thing. But again, I think, you know, how that is done and why, and what happens in your first shot of designing a scheme is quite important, because that determines how it evolves. If you don't get it right at the beginning, I think, then you're kind of stuck with something where it's hard to take the money away, and you're left with trying to just fiddle with it around the margins a bit. So.
Thank you.
Hi, Stephen Jan from the George Institute in Sydney. Just a question to Tony, particularly about some of the positive studies that you looked at. Given that the political reality with the implementation of these programs is often that you need to create probably more winners than losers, and that you need to spend money, the issue then comes up of the sustainability of these programs. Did anybody look at cost effectiveness and budget impact of these successful programs?
It's rare. There's a few, the studies in Taiwan did a bit of that, and also the Avatar quality studies in the NHS looked at cost effectiveness in a certain way. So I think there's only a handful of that, and even when you look at those studies, you know, very few are well conducted cost effectiveness analyses. I think the best quality one will be the one done in the NHS by people in Manchester. So I think that, you know, it's still an issue that governments really do have to spend extra to make it attractive to providers. Those schemes which which essentially use withholds. Essentially, you know, it's the current funding envelope, and we're going to withhold some, and you get that back based on your performance. That's probably a bit more budget neutral, but again, probably less effective because it depends on whether doctors think that that withhold is actually a loss or a gain, and it's not really clear how people perceive those.
My name is Bill Savadoff. I'm with the Center for Global Development in Washington, D.C. I wanted to reflect on the point you're making about the simplicity of these mechanisms, which ones are they're more likely to be responses to simple things than complex ones. But particularly to look at the range of what you pay for. So the fee for service is paying for a consultation, and then most of the schemes we're talking about in quality measurement are moving sort of gradually toward adding something. Did you give them aspirin? Did you add this thing that we think is a good thing for outcomes? But it's not going to the farthest extreme, which would be something kind of like whatever you want to call it, accountable care organization, HMO or whatever, which just pays for healthy people. That would be the extreme, right? You just pay, you're responsible for 100,000 people, you get this amount for each healthy person, and you figure out what quality care is needed to make these things happen. And so I wonder what part of the problem you're detecting in this heterogeneity and what you're describing for the US is that we're enmeshed in this debate about both what actually improves care, and then how do we measure it in a fair way so that we can get providers to be engaged to change the behavior. And if there was a movement more toward the measurement of the health outcomes attributed to populations, you've got a simpler structure for incentives to make a payment system work better.
Yeah, I think that's a really provocative comment. I mean, of course, not that we haven't talked about paying for outcomes, but as I'm sure you well know, if we could measure healthy people or incrementally healthier people, if we were paying for improvement in health, assuming that you wouldn't get credit for people who just come to you healthy, that has a lot of appeal, but huge risk requirements on the part of providers, since there's so much of that they can't control, and huge selection incentives. And so we do see in these schemes increasing use of outcome measures. They tend to be narrow because there are only a few places where we have good outcome measures, but outcomes unfortunately, a healthy person, there's never going to be one measure of that, so they're always going to be multidimensional, and so that kind of complexity, you don't totally get away from it just by looking at outcomes, because outcomes have to do with the patient experience of care, as well as sort of current health status and long-term health status. So I'm not sure that we will ultimately get there, because I think even conceptually, the ability to attribute responsibility for those outcomes to a particular provider is going to be really hard to do. There are just always going to be unmeasurable factors that are associated with that. But having said that, if you reflect on, again, the hospital readmission reduction program, it's a terrible program, and yet maybe it works. But if we were thinking about paying for health, for a real health outcome, I would be really worried about those patients who come from low-income backgrounds, who have other social risk factors that make it hard for them to maintain their health, that the incentives to avoid those people would just be so strong in those contexts.
I mean, I think in the UK, they are measuring patient-reported outcomes after hip fracture and things like that. So they get EQ5D before and 3 to 6 months after, routinely across the NHS for 4 or 5 conditions. So that is happening. They are measuring changes in health-related quality of life. But again, it's not being linked to PF performance yet. There's a lot of analysis about what those measures mean, how can you attribute it. So that is starting to happen. But again, I think one of the issues is that because there are so many different definitions of quality and health and outcomes, what should we be paying for, that there's not a lot of research about what the interrelationship between these different quality measures are. And also there's not very much research about what patients actually might want from the healthcare service.
Hi, my name is Patrick and I work for the Health Policy Plus project. So I was here at this same room on Friday on the Affordable Care Act session, and one of the key takeaways is the total health cost in the US is increasing, and the most successful or considered successful interventions or policies succeeded in slowing down that increase. So is it that bad, considering your perspective, utility maximizing for providers? That's the perspective that you actually presented at the beginning. But is it that bad if the government is trying to control cost through value purchasing? You considered value purchasing as a cover for controlling costs, because getting what you pay for while maximizing quality, I think it's not that bad. And yesterday, we had a presentation at the arena from the UK perspective saying that unmeasured quality is systematically cut by providers. That's one of the things that I also took away. So is it that bad? Comparing these two contexts, and also quality in itself, while trying to cut down costs, is it that bad from a government perspective?
Is it that bad to focus on cost control? Is that what you're saying?
While maximizing quality.
Well, I don't think.
Introducing
Yeah. I don't think,
or-
I think I was trying to say that it's not clear that value-based purchasing is causing anyone to maximize quality. But if it may be neutral and make cost control feasible. So, for example, in the physician payment reforms in the US, they're organized around quality. Given the complexity of that program, it's not clear to me that they'll have any effect on quality, but it was a way for the government to essentially slow the growth in the fee schedule, at least, if not total cost on the physician payment side. That may be fine. I do think, given how much waste we have in the U.S. system and all of the welfare problems with increased government spending on healthcare, that it is anything that slows the growth in public sector healthcare spending. It seems to me to be beneficial, but I don't think the quality outcomes of that are at all clear. So it's hard to measure unmeasured quality improvement.
Thank you.
Hi, Peter Amico from RTI. Thanks for your presentation. So my question's for you, Meredith. I know you mentioned some of the bundled payment arrangements and saying, you don't maybe classify those into value-based payment. But so Medicare is rolling out more of these. I mean, joint replacement, cardiac, which I think is postponed, but anyway, some of these, cancer and as well. And also, I think CMS is trying to do a little bit more on the kind of randomized control design, where like CJR was randomized to MSAs and et cetera. And some of these new ones that are coming out, like Million Hearts and Accountable Health Communities, they're trying to randomize the intervention and kind of get a control group. So anyway, my question is, within the, for example, joint replacement or oncology care, these bundles, I think, and I'm not positive, I don't know if you know, but I assume quality is a component of the payment. And so I think that there's potential there, and maybe you're shaking your head, but...
Not for joints. I actually don't know the cancer one well enough, so
okay.
someone else would
There's
have to intervene.
no functional status type of measures or anything they're doing on joint?
They're just bundled payments.
Okay, so the kind of idea is to just structure the payment and hope that the quality is...
Right, and it's sort of kind of going back to the last point. I don't necessarily think that's a bad thing. I actually think bundled payment, it's very simple. Right. It's pretty clear that that bundling those payments will reduce total spending within the bundle. There's always the question of unbundling. So it may not drive cost control net because of that. Right. We get more of them, or we get costs that show up other ways. But I think actually the evidence is pretty good that bundled payment is an effective way of reducing total cost of care with no evidence of quality decrements. And I certainly, as an economist, very happy with that, if that's what we get. So I think those may be important. It's funny, I was chatting with someone about bundled payment earlier today, and I think the challenge of bundled payment is that each one run is a very complex package of negotiations. What's in, what's out, what breaks the bundle, what happens when you have, your right hip and your left knee, is that one bundle or two bundles? So they're very complicated. I'm not sure that they're a total solution, but I fully support the testing and adoption of them.
And I think quality kind of value-based payment could certainly be built into a bundle.
Absolutely.
Which
Yeah, so
would
these
be-
patient-reported outcomes for hips and knees
Sure.
would be a great complement to that.
Yeah, great, thanks.
Yeah.
Yes, Michael Chung from National Taiwan University. Since you mentioned many times about the Taiwan, I think as a professor from Taiwan, I think the national people fee scheme in Taiwan actually is not typical because it is close to your bundle payment, as you mentioned. Since 2001, we just pay for six types of disease, including the diabetes mellitus, SDM. 2006, we added the outcome measures, hemoglobin and ADL levels as outcome measure. But we started public reporting since 2004. So actually, it is a
Like the
combo.
US
It's a combo.
staged,
Yeah, it's
yeah.
a combo. However, my question is. Since the US, you pick the 5 clinical areas as a premier program. In UK, they pick the 29 clinical area. So my question would be, since the program would be as simple as possible, so how many sites, because since there are so many clinical areas, so including the cancer, non-cancer, whatever, so what would be the optimal size to choose the area? Because not clinical area, how about the patient experience? How about organizational efficiency? So clinical area and that's the different domain. How did you pick the optimal combination to design a POV scheme?
I certainly don't know the answer to that question, but maybe Tony does.
You pick what you can measure.
Well, but so you're always trading off sort of the multitasking problem against the complexity problem, and where the right set of trade-offs is, it's really hard to know.
And I think in the design of these schemes, that there hasn't, although people do pick what they can measure, there hasn't been any complementary research about, well, what actually should we measure if we wanted to measure this properly? Nobody's really thought about that. They've just picked what they can measure. That'll do. They haven't really thought, well, how can we decide on what is actually the best optimal package.
Yeah, so in Taiwan, only the DM may be the successful, but the others, I don't think so. Yes, okay, thank you.
Thank you. Thank you.
So let's thank the panel one last time.